As you know, the SWFIT-DIRECT trial was one of the 6 randomized trials trying to address the question whether we should still administer intravenous thrombolysis to patients who are addressed directly to a thrombectomy-capable center. So we know we're going to go ahead and do thrombectomy because there's a proximal occlusion, but we don't know if we still should do intravenous thrombolysis. So SWFIT randomized 408 patients between the 2 methods, and the results were neutral in the sense that it didn't prove non-inferiority nor superiority of the combined approach compared to thrombectomy alone. Now, for this sub-study, we wanted to address a different question, in the sense that the updated ESOC recommendations still recommend administering intravenous thrombolysis because there is likely an additional benefit, albeit small. However, some neurointerventionists do have some concerns regarding thrombectomy performed immediately after thrombolysis because they might fear the clot fragments. They think that sometimes it leads to distal emboli, which might need additional device passes, leading to a longer thrombectomy and eventually maybe a lower complete recanalization rate. So what we wanted to do was to answer these questions and basically to determine whether the intravenous thrombolysis has a deleterious effect or not on the technical metrics of the procedure, like the number of passes, like the first pass recanalization rate. And we also wanted to determine if the choice of thrombectomy technique would influence in some way the effect of bridging intravenous thrombolysis. Basically, for this sub-study, we included all the patients in the SWFIT-DIRECT trial, with a few exceptions. So there were 15 patients who were treated with contact aspiration, because it's important to mention the protocol of the SWFIT-DIRECT trial required the use of a stent retriever. So in this study, we weren't able to study the influence of intravenous thrombolysis on contact aspiration. We concentrated on stent retriever. So we included all patients from the SWFIT-DIRECT trial, except 15 patients out of 408 who were treated with aspiration despite recommendations, and 7 patients who did not receive mechanical thrombectomy. And then when we had our study population, we divided the patients into 4 groups depending on the stent retriever thrombectomy technique. Because as you know, stent retriever thrombectomy can be performed in more than one way, depending on the use or not of an additional contact aspiration catheter or a balloon guide catheter. So we divided the patients into 4 groups, and then we performed 2 analyses. The first analysis was an interaction analysis between the choice of first-line technique and the effects of bridging thrombolysis. And the secondary analysis, for this part, we wanted, because this is a first-line technique sub-study, we wanted to compare the first-line techniques between themselves. So we compared the 4 different methods to use a stent retriever for safety and efficacy outcomes. For the primary analysis, and in this analysis, we basically wanted to determine whether the choice of thrombectomy technique would influence the effect of bridging intravenous thrombolysis. We did not find any significant interaction. That means whatever stent retriever thrombectomy you choose to do during thrombectomy, the effect of thrombolysis on the final outcomes, whether it's efficacy or safety, will not be altered or changed. However, in doing this analysis, we did observe an interesting and relevant result, because patients who did receive intravenous thrombolysis had significantly higher rates of first pass reperfusion, TICI-2C3. And this was our primary outcome in this sub-study. And we verified this result in the sensitivity analysis by including all patients in the study and by accounting for missing data with multiple imputation, and these results stay valid. So patients who received intravenous thrombolysis have a higher chance of first pass reperfusion when they go to thrombectomy. And in addition to that, they also fare better on several secondary outcomes, like, for example, final TICI-2B3 or TICI-2C3 reperfusion, and also 90 days clinical outcome. So this was the primary analysis. And for the secondary analysis, we compared the 4 stent retriever methods. So basically, this was the four groups were balloon guide, catheter, contact aspiration, and stent retriever. The second was contact aspiration and stent retriever. The third was balloon guide and stent retriever. And the fourth was stent retriever alone, without aspiration or balloon guide. What we observed in this secondary analysis was that the patients who were treated using a balloon guide and a stent retriever without a distal aspiration catheter fared better than the other three groups in terms of recanalization. They had less intracranial hemorrhage at 24 hours and improved clinical outcome. This study is actually in the same line with another sub-study from one of the other randomized trials, which was the SKIP trial. And they also find that patients who are treated with a stent retriever have higher chance of first-pass reperfusion if they receive thrombolysis. However, there are two other studies with kind of discordant results. There was a sub-analysis from the Mr. Clean randomized, Mr. Clean no IV randomized trial, and there was also a sub-analysis from the COMPASS trial. And in these studies, the authors did not find a significantly different first-pass reperfusion rate on stent retriever patients. So overall, two positive studies for stent retriever thrombectomy and two negative studies. We weren't able to address the influence of intravenous thrombolysis on aspiration, but some of these studies that I mentioned did look at that. And there again, we have some conflicting results. One study found that patients treated with aspiration who received thrombolysis fare better, and the other, they fare worse. So overall, we think that our study has some advantages compared to the other. Why? Because one, the data set was very good, so patients were randomized for thrombolysis or not. Two, the study was consistently performed with stent retrievers, so this ensures that our data set is consistent. And third, we also looked at the different stent retriever sub-techniques. So we feel that there is a clear signal that patients who receive thrombolysis and then receive thrombectomy with stent retrievers fare better compared to without thrombolysis. But of course, the ideal would be to perform this analysis again. So as you know, there is the IRIS collaboration that has already published initial results. So basically, this is a patient-level pooled analysis from all the 6 randomized trials. So maybe one option would be in the future to do a comprehensive analysis on this data set, which comprises more than 2,000 patients.